psychiatrist and scientist and assistant professor over at the University of Toronto up in Canada. And thank you for the organizers for having me. The topic that I'm going to be discussing is clinical considerations for feasibility, recruitment, safety in addiction neuromodulation trials. So my disclosures is just various sources of research funding for my research program in addiction and clinical neuromodulation. So I wanted to touch upon, for this kind of overarching topic of trial design and reporting challenges, about these kind of 6 issues that I've been very interested in recently, which is recruitment, feasibility and acceptability, safety and efficacy, comorbidities, pragmatism and implementation, and cost and scalability. So, because of the time, I'm just going to really briefly touch on these only, and then just talk about how we are addressing them in the projects that I'm currently running. Okay, so the very first addiction neuromodulation trial I ever did was trying to address this problem, which we're all familiar with, just the skyrocketing rates of opioid overdose deaths and mortality rates. And though there are many contributors to overdose deaths, suicide may be one. And oftentimes people that die of overdoses have some history of depression or suicidality or intentionality to their attempts. And so because there are no therapeutic options for this specific symptom cluster in opioid use disorder, the question was whether RTMS could fill this gap because of some mechanistic overlaps with the DLPFC. So we ran this pilot RCT of RTMS for suicidality and opioid use disorder. It was a bilateral theta burst stimulation approach with CTPS to the right and ITBS to the left, with the primary outcome being the scale for suicidal ideation. And it was a sham-controlled, double-blind, randomized controlled trial. We were recruiting for 2 years, and everybody had their DLPFC found through anatomical targeting, through neuronavigation. We did a TMS EEG biomarker study before and after. And the course of treatment was once daily for 4 weeks, so that's 20 in total. And this was largely inspired by my mentor, Dr. Jeff Daskalakis, who was in Toronto at the time and was moved on to UCSD, but I continue this line of work with my collaborators over there in Toronto, including Dr. LaFolle and Dr. Bloomberger and Dr. Voineskos. So, like I said, I'm going to mainly touch on these clinical trial reporting and design aspects. So I just wanted to focus on our challenges with low recruitment and retention over the 2 years of recruitment. And so I thought that we had pretty good interest in referral rates and things like that, but it was very, very challenging to recruit these people. This was an outpatient setting and an outpatient RTMS study. And the primary reasons was mostly instability psychosocially with ability to contact them and schedule them and things like that. And then the other side of it was medical and psychiatric comorbidity and instability, which led to often unsafe situations and kind of precarious medical situations where it was not clear that they should proceed with RTMS. But we did get 6 who received RTMS and 2 completed. But even with the 6, they found it challenging one of them couldn't pay for their transportation to come anymore, and the other people went through other aspects of stressors. But there were no serious adverse events for the people that did go through. It seemed like the handful of people did improve on their suicidal ideation, although the numbers don't really tell us much about that. So hopefully we'll be writing that up soon and publishing it. But the main thing that I learned from this was that participants were challenging to contact and schedule for the study procedures, likely owing to instability in their lives. And they had complex multimorbidity, medical instability, precarious housing, and so on, which is well described in the literature already. But this kind of set off this interest of mine to do trials that are modified for feasibility in complex patient populations. So during this, I had this interest about what was done in the current RTMS literature, focusing on methodology, in particular issues with eligibility criteria, treatment settings, and safety protocols. And basically, it's so heterogeneous that it's hard to summarize. But many of the severe complex addictions were done in rehabilitation settings, and they had these complex, long detoxification protocols. But the other thing that we found was it was actually quite poorly reported what people did in terms of thresholds, in terms of substance use for treating, and how long since their last substance use and things like that. But we did map it out, and I think the results were interesting, and it was a good learning experience for me. For time, I'm going to skip over this, but the other aspect that has been interesting is to try to translate things that are starting to accumulate good efficacy data. But implementation scientists will tell you that to get from the knowledge gained part to the translation to real-world practice actually takes a very, very long time. And we always hope that just by doing preclinical and then efficacy studies that we can get this large public health impact. But probably what we need to do is a lot of these other intermediary trials looking at effectiveness through pragmatic trials and implementation trials that have outcomes which look more like this, which is the reach and the adoption and the implementation and the maintenance of your novel intervention within your healthcare system. And so that's what motivated a recently launched trial that was funded by CIHR up in Canada here to do this pragmatic comparative effectiveness trial of this FDA-approved smoking protocol, but to kind of expand to treating our local clinic, our nicotine dependence clinic at our hospital population, which basically just has a ton of comorbidity. Everybody walks in with either some sort of mood or psychotic disorder or severe mental illness. Also recruiting people that may not fit the strict criteria, for example, with number of cigarettes smoked. We were interested to find that a lot of people that just smoke under 10 cigarettes wanted RTMS. And then in terms of implementation outcomes, a lot of it was survey-based, so we were asking questions about how likely it is you can afford things, or that this travel and location protocol is feasible to you. And then we're doing qualitative interviews, looking at barriers and facilitators for patients to accessing their treatments. And so I think this speaks a bit to the patient-reported outcomes that we're trying to figure out are the best ones. And just with the handful of participants we've collected already, they've told us very astute observations of how they don't want RTMS because they don't want their brain changed, which is actually the opposite of what most of us are trying to do. And then, people saying that, this person saying that if this doesn't work in 1 week, then my optimism will wane because I just feel like I'm coming in every day to wear a silly hat on my head, right? So, patients have their opinions too on how long a treatment course should be. The last thing I'll touch upon is our efforts right now to develop a RTMS treatment protocol for cannabis use disorder. And in designing this study, we really wanted to do something that would be down the line, scalable and practical and cost effective. And so this is a pilot study funded by a NARSAD grant that's comparing high versus low frequency stimulation, but we're using the MagVenture MMC 140, which is a circular coil. And this was selected because we figured out that this was the lowest cost FDA-approved RTMS device that we can get in Canada. And it has a central opening, so you can visualize for anatomical marking, and it has as many of you know, wider field of stimulation. So hopefully this reduces technician demand. And then this idea of comparing high frequency to low frequency is that if low frequency is more effective or just as effective, then perhaps that's the more scalable arm, because low frequency stimulation you can have more lower cost and even portable or at-home stimulators one day, or at least it's more likely with low frequency stimulation. So we're doing pretty good 1 year into it, and hopefully we'll finish recruitment in a year from now. And then we can move on to doing placebo-controlled trials. So that is it for me. Thank you to my collaborators and funders, and look forward to the discussion.